So it should be case 71. And hopefully you can see my screen. This is the history. Let me get that here. So it's a young Labrador, history of lethargy and hunched abdomen for 88 hours. And the lab work is pending, unfortunately. Okay, so there were like a couple of images. I put them all because some of them are better in quality compared to the others. Let's start with the, well, whatever you want. I think we have thorax and abdomen. So where would you like to start?
Abdomen.
Abdomen, okay, cool. So, oh, and I need to fix something here. References, viewers. Okay, cool. So we're gonna open this again. And it should be coming here, beautiful. So I don't think we have a left lateral. We just have a right lateral and then a DV. The technique is not the best. So I think you benefit from opening this study like in your viewer probably. Okay. Yes, cool. Let me get my papers, my notes, okay. And again, we think aloud. I am including like, you know, so in this thinking aloud, I would probably encourage you to say everything, like including I have no idea, or makes sense to be very, very open about what you say. And so there is no, in here, probably in this section, there is no, or we always want to be right, but there's also room here to say, you know, for me it looks normal, I don't know, this is very subtle, I'm not sure. Makes sense to, so then we can trigger the discussion. I'm trying to put myself in your shoes and what I would say if I see this case. It's kind of tough for me because I find cases that I really like, and then when I look at them again, I say, well, maybe it's too difficult, but we'll see.
The first thing I was going to say is surprisingly little gas in the abdomen. There's obviously a pocket of gas in what looks like the cecum, but I can't see gas in the stomach, and I'm struggling to see the outline of the stomach. The intestines are very gas-free, and the colon is pushed right down. I can't clearly see the bladder, I don't think, but I can see the outline of the liver and I can see the spleen quite nicely. And I can see the kidneys on the BD view, I think. But I'm missing, I'm missing the outline of the stomach, and I'm wondering why there's no gas. So that's just a basic start.
Beautiful, beautiful comments. So I write them. So GI is no gas. And then you said something about the colon being displaced.
Yeah.
Ventrally displaced. And then the other one is your, let's say, inability to see the borders of the stomach.
Yeah.
So we can say stomach effacement somehow. Okay. And then kidneys, okay, on the VD projection.
Yeah, I think I can see.
Okay, those are very important points. And this, it works beautifully in terms that I'm not sure how much you can make about those findings, but some of them are very important. So it's beautiful to see if someone else can agree, disagree, add more, see if there is an interpretation available for those findings. Yeah, good. This is a good starting point.
I agree with the colon being displaced. And the truth is, while I was watching watching the abdomen, there was something that was shocking me, but I couldn't see what is it. And I think you're right. I agree. Like that, the lack of gas, it's shocking me as well. I have no idea if this is abnormal or not, but
Lack of what?
of gas.
Okay.
Yeah. And the colon, for me, yes, I agree. Clearly ventrally displaced. Maybe there's a mass dorsally. It looks like a mass effect, but
Okay.
I can't see the colon in the VD or the DV. I can't see it.
Okay. Good point. So probably from the only thing to add is this idea that if the colon is ventrally displaced, then I don't know how hard you want to go, but at least there is this possibility of considering a mass effect. And I suppose you're saying mass effect because you don't see the mass. So you're seeing the consequence. Okay. So
Yeah.
I'm going to write down mass effect. Okay. Anything else?
Mariano,
I feel like,
would you mind just on the lateral, just zooming out a little bit, just so I can gauge how fat the dog is? I can't quite see the top of it. Okay, so I guess the ventrally displaced colon could be fat, but it doesn't look like a super fat dog from its like fat over the spine. So that would probably more support the mass effect type thing than if it was a fatty.
Good. So one hypothesis is nothing to be really concerned. It's a variation of normal and probably due to fat in the retroperitoneum. And then you put that hypothesis and then you're immediately arguing with yourself, because if that is the case, then we usually kind of expect like a fat dog, and this is not the case. So that doesn't really fit. Is there anything else that doesn't fit with that idea? I love the idea. So it's always the idea of always saying, well, it's a variation of normal. By the way, I need to find a book or the actual title, I'll do it, which is a book written about variations. And so that's beautiful because, that's a challenge that we have all the time. So something is normal. When it's normal, we are all happy, and then it's the classic. And then as you move into abnormal, there is a transition, there is a gray area where we may find many things that are variations of normal without being black or disease. So being aware of all those variations is very cool. And there's a book written about that. Makes sense? So, and examples about, these are all the variations. These things usually look like this, but it could look like that as well. And it's not abnormal. So that's a very important first topic, idea, and then book that I will share.
I feel like there's just generally the abdomen looks a little bit mottly, even though there is good serosal detail. So I don't think there's an effusion, but everything just looks where the intestines are and over the gas pocket. It just looks slightly mottly.
Okay.
And the stomach, you can see on the VD, the stomach looks like it got ingesta in it with just some very, very small gas pockets, like it might have a stomach full of food. And I'm not sure on the lateral if this is an actual line of a mass, or it looks, the top of it dorsally might be where the kidney is. And I don't know if this is actually a real line or if I'm imagining that line.
Mm-hmm.
I think on the VD, the kidney, I think this is the kidney. Maybe it's a little bit caudal, but I think this is the kidney. So maybe anyway, I can't really see what I was looking at on the VD, on the lateral on the VD.
Awesome exercise. You see something, you want to see it in the projection. Probably what is missing, and sometimes you can't go any further. So what I would probably suggest is, can you consider any other option for that line? So this kind of discussion is the discussions that we have if you do imaging. If you hate this discussion, you hate imaging. We have many discussions about what is that line, and makes sense. So where is it coming from? Multiple options, always multiple options. And this is, if you want to bring it back, basically the problem that we are dealing with is a problem of superimposition. Okay, so we have a 3D object reduced to a 2D image. So whenever we are asking ourselves, where is that line coming from? Actually, the underlying question is, where is that line? Like, at what level? Is it in the abdomen? Is it out of the abdomen? Is it in the abdomen? Structure makes sense. And the problem that we are dealing is the 3D object into 2D image. We usually don't have that problem when we read a CT. Makes sense? So in CT, there is no a lot of discussion about what is that line. Discussions are going to be more what is that represents. Makes sense? So which kind of disease process can result in that? There's a lot less discussion about what is that line. Makes sense? Because what is that line is a question that comes from reducing a 3D object to a 2D image. So a little bit of philosophy here, but I think it's important because the more you can identify what is the underlying problem to your questions, probably the more aware you can be about the solution. Makes sense? So if the problem is, I don't know what is that line coming from, and the classic example is going to be a thorax and something in the mediastinum, and your inability to decide, is that in the lung, is that in the mediastinum, where is that line coming from? Then usually the answer to that question, the underlying problem in that scenario is a 3D image to a 3D object to a 2D image. And usually the way out is a CT. So that's a very normal way of thinking. So if we come back to this comment, you try to make it kidney, but then it didn't work. Do you have any other hypotheses? What else could it be?
I think the dorsal curvature could be the kidney, but ventrally it's, I'm guessing, probably intestine. And it just looks like it lines up with the dorsal line.
Okay, now we are talking about this one.
Yeah.
Yeah, the argument that I would have against the idea of intestine is that it's kind of unusual. I'm not saying that it's impossible, but it's kind of unusual to have the intestine and assume. So it seems that the colon is coming down here. So that's pretty cecum ascending, transverse descending. So I think it would be unusual more in dogs, probably not so much in cats, that the bowel, first is no colon, and second, in that case would be the small bowel, would be so dorsal. And dorsal to the...
I think that might be kidney up there, but I feel like the where it's the lines seem to sort of join in here, maybe there's just some superimposed bowel that made it look like
I see.
Sort of heading ventrally.
Okay. I now I get it. Okay, good. I'm not saying that I'm agreeing, but I understand what you mean. So any other things? Any other findings?
Eventually the liver seems to extend past the costal arch, but the gastric axis looks approximately normal. So I don't know whether the liver's truly enlarged or it's just like anatomical. Also the lung field, the caudal lung field on the lateral looks sort of whiter than expected. I mean, it could be atelectasis or something real. It's quite, to me, they look quite underexposed, the x-rays, so it could be sort of from that as well. Don't know the significance of that.
It's an expiratory film, isn't it?
Yeah. But it's sort of the dorsocaudal lung lobes look whiter than I would have expected.
There's certainly an interstitial pattern, would it be?
I was going to say bronchial, actually, but...
Yeah, I can see both as
You
well.
say potato, I say potato. It's like, I think you probably need a proper
Front
chest
belly.
X-ray to assess it properly. Is Mariano frozen there? He's not moving.
Yeah, I
Not
think,
talking.
or he's just really, really listening, you know.
Okay, we are back. Sorry.
We were thinking you were just listening very intently, and then we realized that you were frozen.
I think it was my internet was like playing up. I'm still sharing the screen, and now I changed the internet, so it should be working okay. So I miss your considerations about still with the normal limits or a variation, or I will not be.
The liver. It's I wasn't sure because the gastric axis is about normal. It doesn't look rotated, but the ventral lung lobes seem to extend past the costal arch. So I guess it could be just like a focal enlargement of the liver rather than a generalized one, not affecting the stomach area. But it could also be just like anatomical variation, I guess. It's, yeah, not sure on that one.
Cool. So this probably I want to deal with now, because otherwise I will forget. So it's very cool that you bring that. That is a very, let's say, common description or concern of people. You know, the liver goes beyond or caudally to the rib cage. And if you go to the book, it's going to say that that's one of the features of hepatomegaly. However, it's the weakest. And by weakest is the one that is the more gray. Makes sense? So we were just talking about that. Normal variation, abnormal. So this is the one that is gonna almost always sit in that normal variation, unless there is something else. So if there are different, and you were considering that, so you're saying, well, it goes caudally to the rib cage. However, the gastric axis is okay. So gastric axis, very cool. So that's the feature that we want to use. That one works a lot better. So if the gastric axis is okay, then we probably ignore that the ventral aspect of the liver goes caudally to a rib cage. Makes sense? So, and then the other one is probably the same thing I would add. Probably the other very important one is the contours. So are the contours normal or they are rounded? So if I need to pick and decide, and it's not me, I think it's like that. If you want to pick which are the most relevant findings, which are the ones that you should pay more attention to, I think there's going to be the contours and it's going to be the gastric axis. The one that you should pay the least attention is the position, if it's going to go more caudally. And one of the reasons is as old dogs get older, the ligaments between the diaphragm and the liver, they get more laxed or loose, and then the liver kind of rotates and goes more in that direction. Yeah. So again, those are the three features. The weakest one, and probably this is mine, I would probably recommend not using that feature unless you have something else.
Yeah.
Unless the gastric axis is abnormal, unless the borders are abnormal. So that would be my way. So beautiful that you brought that, and then also let's clarify that. And that idea about having multiple features, and then based on how many you have, how much you trust on them, deciding how much you're gonna go and trust on that abnormality is a very common situation in imaging. Makes sense? So this is a hint, or this is a very strong feature. If it's a hint, usually we want more. Is this hint and there's any other hint, or it's just an isolated hint? You usually try not to pay attention to isolated hints, or at least make that very clear. Makes sense to say this is a hint. It may not be real. It's just a hint. Makes sense? So findings and then how we read them. Beautiful. Anything else?
I also thought the caudal lung lobes, the dorsal caudal lung lobes, looked whiter than I would have classed normal. But like it's on the edge of the X-ray. The X-rays look quite underexposed, so I don't know the relevance of it. probably need proper chest x-rays to fully assess.
Cool. So unless there is any other finding,
We can't see the x-rays anymore, Mariano.
oh, okay, it should be working now. Is it?
Yeah, that's better.
Yeah.
Sorry, Mariano, have you seen the Helen comment in the chat?
No.
She said that she couldn't see the kidneys in the lateral, and if that could be fluid, blood in the retroperitoneum.
Very good. So what do we think about those comments?
I think it's a really good point.
Okay. So let's go very shortly. Like, do you all agree that we can't see the kidneys in the lateral projection? And if we do agree, well, how many do agree about that?
Yeah, I can't really make them out.
Yeah, I agree.
So if that is the case, let's consider why. Which Helen is already offering one option, which is the good old, border effacement. And the way that it works is if the kidney is soft tissue and you put fluid around, then that's, we call it border effacement, and it's going to make the borders to look you're going to erase the border. So she's offering that option. Do we have any other option?
I guess they're in a place where there's just a lot of overlying tissue, so could just be sort of effacement from other soft tissue stuff in the area.
There's good abdominal contrast ventrally, but not craniodorsally in the abdomen. So it suggests there's fluid that's pocketed or localized to that area.
Cool. So you are supporting Helen's comment. You are adding that I'm trying to clarify and put more words. You're saying an additional feature that supports the idea of fluid around the kidneys as the cause of our inability to see the contours is that actually the contrast in the retroperitoneum looks abnormal. And I think I would probably tie this with a comment about the mottled appearance. It seems to be a mottled appearance or mottled appearance in the retroperitoneum. So that, I would probably tie those together. And any other, then I would probably want to address the other comment about could it be superimposition? And remember that these are two very different concepts. One is silhouetting, and the other is superimposition. So actually, in every lateral projection, or I would say in all of them, but there may be one case where it doesn't happen, the kidneys are superimposed. Makes sense? Because the right one is a bit more cranial, the left one is a bit more caudal, but there is a point where both superimposed. That doesn't stop us from identifying the borders. Makes sense? So when two things are, and here again, we are dealing with the object to the image. When there are two structures, they are both like two kidneys. They are both soft tissue, and they are both surrounded by normal fat. It doesn't matter if they are superimposed. We are going to still be able to see the contours of both. In a point where both superimposed, there's going to be more tissue. And if there is more tissue, because instead of one kidney, there are going to be two kidneys, we are going to stop more x-rays. So that area is going to look more white. But we are still going to be able to see the contours of both. This is coming back to the very, very basic principle. So the conclusion to that thinking process is that superimposition usually doesn't result in erasing of the borders, because the two objects, they are still have contrast and they are only superimposed. The only situation where we're gonna lose the contours is if there is something in contact. So in this case, so two normal kidneys superimposed will not result in erasing of the contours. Fluid around the kidneys will result in erasing of the contours.
And fat around the kidneys?
Say that again, please.
And fat? Would fat erase the borders?
No, fat is going to give you the borders, because remember that fat and soft tissue are from different families. Makes sense? So we are back to the basic, we are back to the grapes. So if you are back to, I can even bring them. So the situation that we are dealing with, and I'm kind of glad that we come back to this. So the situation is, so okay, so so I think it's in here. Okay, so these are the grapes, both grapes. So in this case, the grapes are surrounded, they are soft tissue and they're surrounded by air. The same thing would be if they were surrounded by fat. Makes sense? So fat, air are different, fat, soft tissue is different. So if we have soft tissue surrounded by fat, now we see borders. So it doesn't really, and this is a beautiful example, it doesn't really matter that you have multiple grapes superimposed. You still see the borders. Nice example here. One grape there, another grape here. Hopefully you can see my arrow. I don't know how to make it larger. And where both superimposed, we can still see that contour, we can still see that contour. Where both superimposed, we have what is called summation. So because there's more grape there, so basically it's gonna be more white. If you add water to that thing, so if you add fluid, like fluid surrounding the kidneys, so fluid is soft tissue, the kidneys are soft tissue. If you do that, then basically you have this. So now then there is border effacement. So this is two kidneys superimposed, or a kidney and spleen superimposed, or kidney and bowel superimposed. We still see borders, and as long as it is surrounded by fat. Now you put fluid in the equation. Now you're erasing contours. If we come back here, no one really said that clear, but we were kind of hinting around. There seems to be good detail in the abdomen, but there seems to be bad detail or contrast in the retroperitoneum. So we can see most of the structures. The borders of the spleen are okay, the liver is okay, the small bowel is okay, but we don't see the kidneys. And the kidneys is something that we always see, and we see that characteristic superimposition. So that's an important finding. Hopefully, now we have enough arguments to believe that that is real. We don't see the contours, we see the motile appearance. And there's one more feature that you already mentioned that is supportive.
Yeah, colon.
Yeah, the colon. So now we have multiple features. So it's a subtle change. Subtle, subtle because seeing the motile is subtle. What is not subtle is our inability to see the kidneys. That's strong. Okay, and it goes together with the mass effect, with the poor detail, which explains why we don't see the kidneys. So now we have more than one feature. And I think with that, probably what is left before we go into the thorax is, what are we gonna do with the empty small intestine? Any way to read that?
Well, maybe it's silly, but could it be just because it has not eaten for a couple of days?
Yeah, so the way that we usually read that, I'm not aware of any of that resulting in, or any meaning or any concern attached to an empty small bowel. So usually we are concerned about the opposite. We are concerned about distension, and usually then that's another chapter, mechanical or paralytic. There is someone that I know, and he's very keen on reading this as reading like the two populations, like if there is a mechanical obstruction, the distended and also the empty ones, or a very severe empty small bowel, as a hint of an obstruction somewhere upstream. Makes sense? So that's an option. If that is not the case, in this case the dog is vomiting, so you may consider that. I personally think that's very thin. I would probably not recommend going too hard on that. I would probably, practically speaking, forget about reading small or small diameter, small intestine. Just that's normal. That's not a problem. The problem if it goes the other way. So if it's empty, it's usually because it's not eating or delayed gastric emptying, maybe painful. But I would probably not pay too much attention to that.
That bulge there has me interested too. I can't say that that's normal because it doesn't seem to follow the contours of the muscle of the leg. And I think you can imagine the abdominal wall elsewhere, but it shouldn't bulge down unless it's damaged.
Cool. So that is today seems to be the day of the superimposition issues. So we are dealing with the 3D object or 2D image. That is a superimposition of, that's a facial, not a facial, like a skin fold. So that if you follow that line, comes over. So I agree, goes across the abdominal wall. That is telling you that it's not abdominal wall, and it keeps going up, and there are multiple lines here. So those are all skin folds, superimposed. Again, that word, so it's not within the abdomen, it's outside the abdomen. It's superimposed with the abdomen. So, and that's a very, there are more here, here. There are usually two around this area. So good. Those are points that is good that if they distract you, we deal with them and we move on. The way to decide what is a skin fold is exactly your point. There are things that go beyond an anatomical region. Makes sense? So skin folds usually go from the thorax to the abdomen or from the abdomen outside. Makes sense? So they don't stay within something. It's just superimposition. So let's move on to the thorax.
Before
Yes.
you move on, I'm sorry. Can
No.
you, I just can't, it always can, well, I was thinking it wasn't retroperitoneal fluid just because of the border you see of the epaxial muscles, if that's what it is. Why we can see that if there's fluid in the retroperitoneal space, or we're thinking it might be fluid plus fat, therefore you get some summation rather than just effacement of the epaxial muscles.
Excellent argument. I love people arguing, and I probably will have like a gray answer to that. And the way that I would probably answer to that question is that this is not all or nothing. The amount of fluid that there is in that retroperitoneum is not huge, and it probably mostly surrounding the kidneys. So there's still some degree of fat against those muscles. So again, it's not an everything or nothing situation. Similar when there is a like a mild amount of peritoneal effusion. We usually argue, and are those contours sharp enough, or they are a little bit not sharp enough? So there's a point where, depending on the amount of fluid, that feature is absolute and is very clear, or it's just subtle. So in this case, I think the amount of fluid in the retroperitoneum is not huge.
Okay.
It's enough to make the borders of the, I can even actually even bother you a bit more. I think probably the borders of one of the kidneys, the left kidney is somewhere there. So in this case, it's superimposed, but the right kidney is not that clear. And I think there's a motile appearance. So there, in this case, that's why when I put the case, I was a bit like, there are hints. If you've been looking at images for a long time, I think you say, I'm sure about it. I understand that you may not be sure about it because there are only hints. They are not like, this is not a huge mass. This is not like a severe amount of fluid. This is a mild amount of fluid. And that's why it's not an everything or nothing situation, it's an in-between situation. I'm very glad that you identify that abnormality. And so and it's not an easy abnormality. Yeah.
Do you have any CT scans of a dog with a retroperitoneal effusion? Because I can't anatomically work out the sort of like the lateral borders of it, how far we would see where it extends to.
So I'm happy to find one, and actually there's a beautiful case that I have. I'm not going to tell you what it is, but we can bring it. And I think I have the radiographs and then so we can talk about the radiograph, the different options, and then bring the CT. The answer to that question about how far does it go is a very hard question, and I think it's a very flexible boundary. So in some dogs, they dorsal, and if it gets abnormal, it gets more ventral. And if for example, if there is a big kidney because there is a mass, it has been there for quite some time, then it can also move and displace ventrally, and it's still in the retroperitoneum. So probably more than trying to decide what is the landmark, what is the line dividing retroperitoneum from peritoneum, I think it's probably better to think about which is the structure that is affected. So if I don't see the kidneys, the detail, the walls of the kidneys are not very well defined. Well, they are in the retroperitoneum, so I'm gonna blame the retroperitoneum.
Yeah.
Make sense?
Yes, thank you very much.
Yeah, rather than trying to identify that border. I think you can see it in CT, and you can see it even nicer if there is effusion, because you can see that border and that doesn't want to go into the peritoneum and it stays in the retroperitoneum. If we think, and I'm happy to bring that case, but if you think about radiographs, probably retro is always a bit more dorsal, but only relying on finding a line or having a landmark, I think it's not going to work. It's going to work more if we think about which are the structures that are affected, which are going to be the kidneys.
Great, thank you.
Cool. So let's move on to the thorax. So here we do have both projections. And then we have the DV, so we can put all of them. Yeah. I'm sorry, it's a difficult case, but I'm glad that we managed to go through, and I've been just guiding you, so you really found all the features. And now it's going to be a challenge to put all of the findings together. But the findings are subtle. Nothing, looks normal.
Fields, but at the same time, I can't work out if it's just that the X-rays are underexposed.
Okay.
Contribute.
So what's your finding?
So there's increased opacity more so in the cranial lung fields, and I think more so on the right-hand side on the VD. And it does seem like it goes all the way up to the edges of the lung fields as well. But yeah, I find it very hard to even visualize the spine, which makes me think that there might be, underexposure of the X-rays, and that could exacerbate what I'm seeing.
Beautiful. So that thinking process is just beautiful. That's the way we think. We see something, in this case in particular, this applies like 100% to the lung. So we say, well, the lung looks a bit too wide. And then immediately after we say that, unless there is a nodule, unless there is an air bronchogram, which we can make up an air bronchogram, makes sense. So an air bronchogram is either atelectasis or fluid, whatever fluid, that we can make up. Then a diffuse increase in lung opacity, we can make up. There are many technical situations where we may end up with that in a normal dog. So then we need to consider those. So one consideration is that is it underexposed? Excellent question. Then we're going to decide if it is or not. Then what else could be happening? What else can result in a diffuse increase in lung opacity being normal, like in a normal dog? One is underexposure. The other one, these I recommend always. Expiratory, very good. So then we can come back to this triangle here and say, Yeah, is it inspiratory, expiratory? Usually expiratory, we have superimposition of the, there are other ways to deal with that, more technical, like you can see how far the lung goes on the DV projection, the costochondral angles, or the, you know, these. Another, and it's worth reading about that. Probably the one that you can use is the hard superimpose of the diaphragm. If there's a separation, or if this triangle is large enough, probably we believe that it's not expiratory. If they are superimposed, like probably in this case they are a bit superimposed, then we believe there is a bit expiratory. So, but that's one consideration that is critical. So to insist, another way to expiratory studies one, very important consideration. The way to deal with that, and like an easy, fast way, is to see the position of the heart and compare that with the ventral aspect of the diaphragm. There are more hints in terms of how to measure inspiration or expiration based on the position of the diaphragm. We are not going to go to that now because we don't have enough time, but that's worth reading. Is there anything else that can result in increase in lung opacity?
Atelectasis?
Yes, but that is kind of a real situation. Makes sense? So it's not that it's a purely normal lung. So the ones that we thought before are situations where we have a normal lung and you underexposed, so it's normal, but it looks wild. And then the other one is expiratory. The lung is normal. It's just a physiologic. We just were unlucky to get the radiograph when it was doing the expiratory phase. In atelectasis, it's still abnormal. It's abnormal. Makes sense? So I understand what you mean. It's not, let's say, a disease. It's probably, it could be, but it could be positional atelectasis. It could be, you know, you were positioning the dog, and that's why. That's one option. Another.
I think the front legs aren't very far forward, but quite thick skin.
That brings the third group, and the third group is superimposition. So again, if you superimpose the 3D object to the image, it's not that you're gonna erase, makes sense? So you still see the heart, you still see the vessels, but the overall opacity is gonna be increased. And you can have that superimposition either because you have the limbs or because there's a fat dog, and the fat dog has a very thick wall. And that wall, again, is not against the vessels, it's not against the heart. That's the reason why you can still identify them, but it's going to provide a diffuse increase in the opacity. Okay, so before you make a call about this lung being diffusely increased in opacity, anytime there is no nodules or something like an air bronchogram, which is, it cannot be explained technically, that has to be real, please consider, is it inspiratory or expiratory? Is it a fat dog? Is it the exposure correct? So those, if you want to remember something, remember that, because that is extremely useful, and I probably would suggest mentally going through that process anytime you read a thoracic radiograph. Okay, but if you go back to the comments, this lung seems to be more opaque compared to that lung. So unless there is some atelectasis, that probably is real. If we go back to the options, is it expiratory? It's not severely expiratory. I don't think it's a fat dog. We talked about that before, so that's not the case. And in terms of exposure, I don't think it's too bad. We can still see detail in the abdomen, and we usually want less exposure in the thorax. So I don't know, we can argue about this, and this is very weak, but I do think there is a diffuse increase in lung opacity, and I think this is a classic, I would call it interstitial pattern. It's very hard to see small vessels in the periphery, very ill-defined borders, probably more here. But I understand that this is subjective, this is always a possibility to argue. I think there is also thickening of the airway, the wall of the bronchi. Probably that's secondary to the changes in the interstitium going against the airway. I don't know, there's no one that can know about that. But I do believe that the lung is diffusely abnormal. Okay, now the conclusion. What is it? What's going on? How can you put these findings together? So let's assume that I'm right and there is a diffuse increase in the lung opacity, and let's be sure, let's trust that there is fluid in the retroperitoneum.
It could be hemorrhage,
Okay, good.
like
Let's go.
like coagulopathy.
Okay, very good. So then that could explain fluid in both. Okay. Let me go back to the history. Okay, so it's a young Labrador, so then hemorrhage could be, yeah, that's a good differential. With lethargy and hunched abdomen, so there seems to be some pain. What else?
I'm wondering about trauma. Initially, I was going to say he had typhlitis, but it's obviously more systemic than that. And just to give him one disease, I'll go for trauma. But I don't see any broken ribs or anything like that, which I would probably expect with a trauma as severe as this.
I agree, and I would probably argue against the trauma. I think the thorax is hard to explain by trauma, because usually contusion is more, it's not focal and well defined, but it's more unilateral, or it's not so diffuse. So this seems to be a systemic disease. Probably the trauma, the option of trauma could explain the pain and could explain the retroperitoneum. I mean, if there is a trauma and then there's bleeding from the kidneys, or a ruptured ureter, or a ruptured kidney, I mean, those are options of a uroretroperitoneum. That's a possibility. And then what it doesn't really fit is that there is no history, that there is no any other evidence of trauma, and then the lung changes are very diffuse. Again, this is an exercise, so we put a hypothesis and then we see how well it fits, how strong is the hypothesis. So any other hypothesis?
Could it be a migrating foreign body into the retroperitoneum from the stomach? Like a skewer?
Yeah. So, or a foxtail that can inhale and then go through the airway. So in that case, to go against, or to find the weakness of that hypothesis, usually that goes with some degree of pleural disease. Makes sense, because as it goes through the lung, it needs to go through the pleural space. And if I remember right, the paper that described that, there's almost always some degree of pleural disease. By disease, I'm mentioning pneumothorax or effusion, and there's usually like a focal increase in the lung opacity here, which is where the foreign body kind of sat for a while, and then it went through. So that, again, doesn't explain the diffuse changes.
I think we had one at Sasha a few years ago where like it was like a skewer, and it had like migrated abdominally though, like from its stomach or something like that up into the retroperitoneum. So I don't know whether that would cause lung stuff, but
no, that's perfect. And we are still missing the explanation of the lung.
I guess I was thinking just sort of systemic inflammation, like
sort
of non-cardiac pulmonary edema, sort of SIRS lung. Yeah.
Beautiful. Yeah. That's an option. I remember I had one that it came with a focal pneumonia in the accessory lung lobe, and actually it was a skewer coming from the stomach across the diaphragm into the accessory lung lobe, almost pinching on the left atrium. And wow. I have that. I can show you. I don't have the radiographs, unfortunately, but it was very cool. Yeah.
Like a vasculitis or a hypoproteinemia. If it's like if we think it hasn't been eating for some other reason, then maybe it's got fluid leaking into the interstitial space.
Cool. So then that goes almost together with the coagulopathy. So there is some degree of leakage, either because there is a coagulopathy or because there is a vasculitis, and it's leaking in the lung and it's leaking in the retroperitoneum. Yeah.
I guess could it have just like a primary like kidney problem, like a pyelonephritis or something like that? I mean, it'd be unusual in a 1-year-old dog, but like where it's just like the kidneys are inflamed and there's fluid there for that reason.
And then probably the disease that is affecting the kidneys and resulting in fluid around the kidneys. is also resulting in vasculitis. So can you think about a disease that can affect both?
Lepto?
Yeah. So this is a case of lepto, and this is the textbook case.
Whoa.
This looks, yeah. So
2017 is a while ago.
say it again.
Oh, it was in 2017. That was a while ago. Was it a Sydney case?
Oh, I don't even know. Yes, it was a Sydney case.
Wow.
Yeah. And it
Yeah.
was confirmed.
We had a puppy at Nev's a few years ago that had lepto, 6-month-old. That was probably around the same time.
Oh, cool.
Yeah.
I've seen lepto in dogs years ago in the Sydney area that have come from poultry farms, and also from areas where there have been cattle, like say dairy farming areas that became urbanised.
Interesting.
I remember seeing this in Europe a lot. And then if you show this combination of findings, if you show like a resident in, like I was in Zurich, if you show them this image, like a thorax with diffuse increased opacity of the lung, and then you look at here and see kind of a mass effect, poor detail, they jump on it because they see it every day. So yeah, it's a bit more common. In Italy, I think it's very common as well. This is the ultrasound, and there is a bit of fluid around. So the idea of blaming the kidneys, either coagulopathy or blaming the kidneys, remember that the fluid around the kidneys is not always present, but it's one of the features that we use to decide or to separate between a chronic nephropathy from an acute nephropathy. So, and I was difficult with you because I said lab work pending, but there were already hints of a renal failure in the lab work. I removed that because I thought it would be too easy for you. Sorry.
It's just
Thank you.
The fluid is just leaked out from the kidneys.
I think in this situation is an acute nephritis, or yes, acute nephritis. And then I have one. I probably would not show you all of this because there was another case that I thought we would go through. But there is a case, I was going through the literature, and you will see that there are more papers because the next case is somehow tied with this case, and I wanted to present 2 or 3 papers, but there's one paper where they go, and the topic was around changes surrounding the kidneys. So in this case, there's fluid surrounding the kidneys, and then basically there's this paper where they found fluid around the kidneys in these many disease processes. So nephrotoxicity, lepto, interestingly, obstruction of the ureter, lymphoma, ureteronephrolithiasis, urethral obstruction, which is very interesting. So it seems that it's either an inflammation, either you have an inflammation or you have a backing up, an obstruction, and the obstruction can result in leaking of fluid, interstitial nephritis, ureteritis. And then they go into the pathophysiology and say ultrafiltrate associated with tubular back leak into the interstitium that overwhelms the lymphatic drainage. So that, for me, is more the pathophysiology of an inflammation. But then they said it could also be urine flow or interstitial flow, obstruction to urine may also play a role. So it seems to be, and there may be both processes. So like a leaky tubule and then increased pressure can result in this oozing of fluid. And usually oil there, and this was the topic, there is a mixture of nephritis, infectious nephritis, neoplasia, or obstruction. I want to remember those 3 as options to offer if there is fluid around the kidneys. In my mind, it's usually the ones that I had always present is acute nephritis and then neoplasia, in particular lymphoma. So coming back, could this be lymphoma? And we recently got a case, a similar case. And could this be lymphoma? So the situation of lymphoma in the kidneys is more like a cat situation. So I think it will be unusual in a dog, but it's a young dog and lymphoma can happen. So probably I will put a needle in there. Yeah,
Right.
I think there was enough
Good
enough
case.
abnormality lab work, not to consider neoplasia.
Mariano, what does ARDS look like? Does it look anything like this?
Oh, very good, very good. So now you're bringing me back to the other paper. Yeah, yeah, that's okay. So the other paper is, how do the kidneys look like? So basically, the kidneys are enlarged. There could be pellectasia. There's increased cortical echogenicity. That's the one that I always remember. The ones that I've seen always hyperechoic cortex. They are usually enlarged, like in cases of acute nephritis, usually enlarged. Or that's a feature. Perinephric effusion, and then in some cases there may be a medullary rim, hyperechoic rim. So that is fluid around. That's how the kidneys look like in lepto. And then there is the other paper that I wanted to also share with you, which are how do the lung looks like in cases of lepto. And this is from Switzerland, and these were two of my mentors. And then what they say is a reticulonodular pulmonary opacity. I would probably translate to you like as a diffuse interstitial pattern. So it's basically how that case looked like. It's diffuse increase in lung opacity. It can turn to be a bit nodular. I more than the pattern, I think the important thing is that it affects the entire lung or caudodorsal. So basically, in my mind, I keep and then they go through the differentials. I said, it's usually due to endothelial damage, or they think that the endothelial damage like a leaky vessels, like vasculitis. And then the differentials, they say, well, this should be considered as a differential in cases of, or could be confused with, diffuse neoplasia, pneumonia, edema, hemorrhage due to DIC, or acute respiratory distress syndrome, or pulmonary thromboembolism. So in my mind, this is one more disease that goes into a diffusely wet lung, into the non-cardiogenic edema, into the leaky vessels, into the vasculitis group. Makes sense? So it's in that group. So and then you need to start finding other hints, to support your idea. But I don't think purely based on radiographs you can differentiate this from a DIC or a coagulopathy or acute respiratory distress syndrome or other causes of non-cardiogenic edema. Makes sense? So radiographically, look, in my eyes, it look the same. It's one more differential for those.
Mariano,
Now,
do you know if the
if you add the
cases? Sorry.
Sorry, I just wanted to say that if you add the changes in the kidneys, then the list comes down a lot more. Makes sense? There are less differentials. Sorry.
No, I was just going to say, do you know if the cases that we've had in Sydney, they've had the similar lung changes, or is it a different serovar here?
Oh, I don't know that, but this is the case that we got in Sydney, and I think the lungs
Yeah,
are.
that was Sydney.
I've seen.
I wonder how many of the lepto cases have had chest X-rays though. Like,
yeah, I've never really even thought about the chest. No,
yeah,
that's really interesting.
Interesting. So maybe a different. Yeah, I remember seeing many radiographs, many dogs that they were panting, and there was some degree of dyspnea, and they took radiographs, and then this is the classic. You see this pattern in the lung, and then you look into the retroperitoneum, and you see a little bit of a mass effect, and you say, oh, no, there is this combination of findings, which makes it more to think more towards this disease.
Cool. Good one.
I think this came because we had a case in the clinic that we were considering about. We had fluid around the kidneys, and we were talking about the options of neoplasia, or there was a dog, and we were trying to differentiate chronic versus acute nephritis, and that's why I thought this.
We've had a run of azotemic disasters in the last couple of weeks, Mariano. They're all blending into one.
Yes, it was your case.
Yeah, we had about 3. We had 2, another one over the weekend. So yeah. And there was one during the week as well.
I started searching, and then I have a database, and it's interesting because when I put the searching criteria, then very cool cases come, and then so I may if I find cool ones run kind of a series. So like it's similar but different cases, make sense? So like we did with the pleural, like unilateral pleural disease or unilateral lung disease, makes sense? So they share some features, but there are some others that are slightly different that makes you think that you should go one way or the other. Makes sense? It's around the topic. So the next one that is there for next week is somehow in the topic, and it's not going to be the same disease, but somehow we are going to continue the conversation. Make sense? Some of the things that we talked about today, some of the ideas about differentiating or finding things or what do they mean, we may use next time. And if it's cool, then I may add like another case, again, in the family, in the group, not the same, similar, where we use the same tools. Okay. Enough.
Cool. That was a really cool case. Thank you so much.
Good one. Thanks, Mariano.
Thank you again, Mariano.
Cool. Enjoy your